SIP or spontaneous entrance perforation typically happens by 5 to 10 days or sometimes even earlier. The more premature the baby, the earlier it happens, and it's typically seen in the extreme premature babies who are below 28 weeks of gestation. The more premature in the extreme preterm, like 24 to 26 weeks, are at higher risk. It's typically associated with the hemodynamically significant PDA as well as with PDA treatment, especially if you're using ibuprofen or indomethacin. And if there is a concomitant use of hydrocortisone for high blood pressure or hypotension or any other concerns, it's more likely to happen. There is a lack of clear association with feeding. Obviously, this happens very early in the extreme premature babies, and you're usually just on trophic feeds at this stage. There is another entity called meconium obstruction of prematurity, which typically happens in the extreme premature where the gut motility is immature, the meconium is more viscid, and it doesn't empty. The baby doesn't pass stool even with suppository. There is persisting feed intolerance. So in these babies, sometimes omnipaque water-soluble iodine-based contrast first given as an enema, and if it persists, we can give it as upper GI contrast. You don't expose the baby to as many radiographs to reduce the radiation exposure. The main aim is to act as a therapeutic effect with this the IOPAC absorbing more fluid. It makes a meconium less viscid and helps to pass, and subsequently the baby may start tolerating feeds. This meconium inspission may be predisposed to SIP as well. And obviously, as I have discussed on the video on RDS and pragmatic approach, we use higher pressures with NIPPV if you don't use surfactant on time, and this may predispose. So this is one of the reasons why you may want to give surfactant early in the course rather than later.